Yes, sir, we are live.
Okay.
Okay.
Good morning, everybody. I'm Dr. Pankaj Garg, right now President of IP Delhi. And on this platform, on behalf of IP Delhi, I welcome you all for today's second masterclass on pediatric intensive care. So this is a very successful program. We have got a lot of registrations and people are very attentive. And even the last session lasted for more than 1.5 hours. That shows the strength of this program. And today also we have a very interesting topic, the airway pulse. We all understand that as all malformations can be, airway also can be malformed, and it will manifest very early in life. So it will always be encountered by a neonatologist or a pediatric intensivist. And we understand that whatever makes sounds may not be benign. We all used to think that congenital laryngotracheomalacia is the only condition which causes some sounds and some airway malformation, but there are many more to this. So we have a very interesting session lined up, and we have very great speaker, Dr. Naresh Lal, on this. So just my duty is to just introduce the topic, and I welcome Dr. Maninder, who is the coordinator of this program, Dr. Ketan Kulkarni, Dr. Mohite in his absent, Dr. Sham Meena, our Secretary of IP Delhi, on this platform. And I now hand over to Dr. Sham Meena.
Hello, good morning, friends. On Dr. Meena this side as a Secretary IP Delhi. On very warm welcome on behalf of Indian Academy Pediatric Delhi State, and I would like to welcome our chairpersons, Dr. Kulkarni and Dr. Mahesh. And I would like to thanks to my colleague Dr. Naresh. He agreed to taking the as a speaker today's session. And thanks Maninder for making the wonderful program this and. I'm just looking the you are the taking the or one of the pioneer field speakers as a pioneer field in these areas. Dr. Naresh is a senior consultant in pediatric ICU as well as pediatric allergist at the Max BLK Hospital, New Delhi. He's a qualified pediatric intensivist. He did the fellowship in critical care from the Kachi Kamakoti Hospital, Chennai. And Dr. Naresh is also serving as a secretary IIP Delhi State PICU chapter. And Dr. Naresh had the actively involved in their field in the numerous publication as well as made the actively involved the guideline related to pediatric critical care. Over to Dr. Maninder.
Hi, everyone. We are pleased to have Dr. Naresh, but let me introduce the moderators. First, we have Dr. Ketan Kulkarni. He is a DM pediatric anesthesiologist, trained in Maharashtra, Mumbai. Then he went to UK, did his further training there for a period of years. Then I had a pleasure of working with him at Amrita. Now he's leading the pediatric anesthesia program at Dinanath Mangeshkar Hospital, Pune. It's really a pleasure because I learned a lot of new things from Ketan, and Dr. Mohite will be joining soon. We'll introduce him later. I'll request Dr. Naresh to please carry on with his deliberations. Welcome all. Dr. Naresh.
You're not audible. Naresh, your voice is not coming again.
You can not coming. We cannot hear you, Naresh.
Are you on mute, Naresh?
नहीं, mute पे नहीं है.
No, he has an issue with the. No. Try once.
बीच में आ रही थी जो आपने
हाँ.
शुरू भी की थी, भी आ रही थी जब आपने दोबारा किया था. आप कुछ
Remove the mic. Remove the mic. Talk directly from laptop.
अब आ रही है वासु?
हाँ,
अब आई
clear है.
अब आई.
Start from the first slide.
Okay. So I was saying that thank you, team IIP Delhi, for giving me this opportunity to speak on a very important topic. This topic looks easy because every one of us has used oxygen therapy for all our patients on an everyday basis. But then we have to learn the nuances and we have to learn when to escalate the oxygen support. So we are going to learn that in today's presentation. So I'll begin my talk. First, we will understand what is oxygen therapy, when it is needed, and then we'll look at some of the important delivery devices which have been using over the years. And then we'll go on to understand some basic airway management techniques. And as an intensivist, I will also speak on an advanced airway management in sickest of our patients. And if the time permits, I will take on you to some cases. So I begin my talk with a very general slide of how the pediatric airway is different from a adult airway. So if you look at this figure, we understand that children are not adults. Their airway is different. So the basic difference here is basically in the shape of the airway. So this airway is, as I can show, this airway, it is not cylindrical in case of children. It is not like a simple tube where you just put whatever devices you are using. It is very difficult to insert these devices in the children because the airway shape is different. It is more conical in case of children, as we can see in this photograph. And the important clinical point here is that this airway can get easily blocked by a very trivial thing like a secretion. So your nasal secretions only, your oral secretions only can block the airway. And the first and foremost thing is to protect the airway from these secretions only. Another clinical thing is that any edema, any infectious cause, or any foreign body can get very easily lodged up in this airway and can lead to catastrophic changes. So important point here is that the narrowest point of the airway in children is not your vocal cord. It is actually below the vocal cord in the subglottic area. And there clinically, we see a lot of cases getting subglottic stenosis in cases who are on prolonged ventilation. So oxygen therapy, what is oxygen therapy? Basically, in children who are in distress, who are hypoxic, we need to have oxygen support over and above their ambient room air which they are breathing. So this in oxygen therapy, we are giving oxygen at a higher concentration. We know that the room air concentration is just 21%. And here we want to give higher oxygen, maybe like 40%, 60%, or 100%, and at a pressure which is higher again than the atmospheric, so that the oxygen reaches till the alveolar and to the tissues. So basically, we are trying to get a normoxia state, which is vital for the functioning of all the organs in the body. And inadequate oxygenation, if it proceeds or if it is unchecked, can ultimately lead to organ dysfunction and death in sickest of our children. So when we talk about oxygen therapy, we need to understand that what is basically increasing the oxygen in the body. So basically there are two things only. One, the oxygen delivery that is DO2 is depending upon your cardiac output, how much your cardiac function is happening, how much the blood is being pumped, and it also depends upon the concentration of oxygen in the blood. So as clinician, we should not always be looking only at the SpO2. SpO2 is just a surrogate marker. For us, the delivery of the oxygen at the level of the tissues is also very important. And that we get from this formula, that is cardiac output into concentration of oxygen. So cardiac output, as I mentioned, it depends on your cardiac function, which has to be optimal. And it depends upon your concentration of oxygen, which is given by the formula 1.34 into level of hemoglobin into your SaO2. So SaO2 definitely you need to increase by giving oxygen support, but then your optimal hemoglobin should also be there. So together, this will improve your microcirculatory oxygen needs and will lead to improved outcomes. At bedside, how do we assess hypoxia? So hypoxia can affect all your systems. Okay. We have seen bronchiolitis kids coming in this influenza season. We see them hypoxic, saturation around 80-85%. They are so much irritable. So that is the first sign. A lot of irritability will be there. The child will be tachypneic. The child will be distressed. There will be tachycardia. Heart rates going 150s, 180s in small infants. And we are thinking, what is happening? We are giving them a lot of nebulization, but it is not improving. The basic thing first is hypoxia. You need to take care of that. Okay. And if this need is not met, the oxygen need remains unmet, it can progress. It can lead to metabolic consequences, causing lactic acidosis, and the child can become comatose later, and he can even have hypoxic seizures. So we have seen this happening in front of us in the ER where the support was not properly adequately given. Then we go on to lab parameters. You look at your blood gases, look at your lactates, and you look at your PO2s, SCO2s, you can calculate your PF ratios. We know that in ARDS, these ratios are very important. And with that, we can measure how much hypoxia, how much oxygenation defect is happening, and we need to take corrective measures. So any patient who is hypoxic, saturations less than 90-92, we need to keep them on oxygen support. Plus, if they have some myocardial dysfunction, or if they have worsening lactates, or the child is going in for respiratory failures like before intubation, so oxygen support is mandatory in them. There comes a concept of permissive hypoxemia. So what is permissive hypoxemia? So thing is that oxygen is also a drug. Like all the drugs, we have to use oxygen judiciously. It is not like we have oxygen, just connect the child on oxygen, make it 10 liters, and everything is done. It is not like that. Oxygen is a drug. You have to use it moderately. You have to understand that oxygen has side effects. Oxygen can lead to absorption atelectasis in the lung. Lung collapses can happen, or it can lead to free radical generation. There might be a clinical subset of patient where excess oxygen may be bad, like in case of your chronic ventilated patients or neuromuscular patient, where giving only oxygen will hurt the child. In the acute, in the emergency room, it is fine. You can give oxygen, but understand the physiology, understand the clinical condition, and then give. So now we understand that the target SpO2 is not always 98 to 100%. Normal may not be normal every time. Target somewhere around 88 to 92 or 92%, and that will suffice most of our children, especially the ARDS patients. Even for bronchiolitis, saturations 80, 88, 90 is somewhat acceptable in many cases. So in my further talk, I will tell you the devices we have been using every day in our emergency rooms. So let us look at some devices, okay? So these are basically devices which are handy to us. Any patient coming to the emergency room, these devices are easily available. So the most common in that, what we use is a nasal cannula, okay? So the child is hypoxic. First thing we have to do is we have to support him with this with oxygen. We have to increase the oxygen reserve because the child is not able to maintain the saturation, and we start the therapy with the easiest one which is available is the nasal cannula, and gradually we'll escalate depending upon the FiO2 requirement. So we classify these oxygen delivery devices as low flow and high flow. What do you mean by low flow? As the name suggests, the flow here of the oxygen is less, meaning the child is tachypneic, the child is distressed, his ventilating requirements are very high. A normal adult or a bigger child may be breathing at around 4 to 8 liters of the normal air what we are breathing. But in conditions where the child is hypoxic, where there are pathological conditions like pneumonia or bronchiolitis, the requirements are very high. It can go up to 20 liters, 40 liters. So how do you support that? So you need oxygen support, and for that, in that, oxygen is given along with ambient air, and that is what is happening in a low flow system. So in a low flow system, the oxygen is given along with an ambient air, is a mixture of that, but these rates are lower than the patient's inspiratory demands. So what happens that because you're giving oxygen at a particular limit, because of the device which you are using, the extra flow has to be is coming because of the air. The oxygen is mixed with the air, and the FiO2 which is given to the patient is not fixed. It depends on a lot of factors: how much the patient is breathing, how much the demand is there, and whether the device has been properly fitted on this face or not. So all these factors will limit how much FiO2 you can get from these devices, and that's why I say it's a variable FiO2 with a lot of diluted oxygen is going in this, versus a high flow system where you need to increase the support, where you need to give a fixed amount of FiO2 because the child is more sick. I cannot manage him on a low flow where I don't know how much oxygen is giving. If I say the child needs FiO2 of 60, so that means I need a device which can reliably give me a FiO2 of 60, and for that I have to use a high flow system. And basically by high flow I means it is giving gas flow rates are very higher than the patient's demand. So patient may be needing 20, but we are giving very high flows, maybe more than 20, like 30 or 40 liters. So all his demands are met, but a fixed amount of oxygen is given along with a fixed amount of ambient air, and we get a fixed FiO2, which is very useful for titrating in these patients. How exactly we do it, I will come in a next few slides. So basically, it doesn't mean that a low flow will give a low FiO2 or a high flow will give a higher FiO2. It basically depends upon the clinical condition and the device structure. I will come to that in a next few slides. So let's start with the easiest one, the nasal cannula. So basically, these are just plastic tubes. You just put them in the nasal cavity inside the nares, and you just start the oxygen. And by oxygen means you have an oxygen port. You start it like 2 liters. You can go up to 4 liters, and that will deliver some FiO2. But you don't have any method of knowing how much FiO2 is going. You can look at the saturation. Saturations will improve. Child will become better. That is only clinically you can make out. But how much FiO2 is going, that we cannot estimate from this. And there are limitations to the flow which you can give from a nasal cannula. So for a nasal cannula, the upper limit is like 4 to 6 liters. Beyond that, if you give, it is a dry air, it's a dry oxygen is going, it will be very uncomfortable, and it is not humidified also. So it might lead to drying of the secretion. The child will not tolerate it. Child will become very irritable. So there's a limit to the amount of oxygen you can give to this child. So flow rates up to 6 liters we can give. Beyond that, it is not comfortable. There's a rough formula where you can estimate how much Fi2 is going. That if you consider the ambient room air as 21%, for every 1 liter of flow which you are giving, an extra FiO2 of 4% is going. So if you are giving 2 liters of oxygen, so 4 multiplied by 2 is 8 plus 20, so around 28. So 2 liters of air in a nasal cannula will roughly give you about 28%. But that again, it is not fixed. It depends upon what is his ventilatory requirement, how much of the air is being diluted, and how much is the nasal prong, whether it is inside or it is lying just on the lips. So it depends on lot of factors. So I don't have control on the oxygen here. So it is easiest to use. Many patients do tolerate it. But the disadvantage is that there is no humidification in this. And as I said, FiO2 cannot be regulated in this. Now, a child is getting worsened. He needs more oxygen support. So you cannot rely on only on the nasal cannulas. You need to escalate the support. And then you choose the next best support, which is the face mask. So in the face mask, basically what we are trying to do, it is a plastic mask as shown in the figure. That green thing is the whole mask. It covers your nose up to the mouth. And this plastic thing, this whole volume acts like a reservoir volume. So oxygen is coming through the pipe below, through the oxygen inlet, and that is filling up the reservoir, and you are breathing the oxygen through it. But what about the exhaled gases? The child is breathing out also. So all the exhaled gases, they come out through these exhalation ports so that CO2 is washed out. And the oxygen what you get here depends upon the flow rate. So minimum amount of flow rate in this mask to wash out the O2 and to support the breathing is around 5 to 10 liters of oxygen minimum you have to give. Below that, if you give it, a lot of CO2 retention will happen. So if you give a oxygen rate of around 5 to 10 liters, you can expect a FiO2 of around 50%. Again, if you use that formula, which I mentioned before, roughly around up to 50% of FiO2 you can regulate with these masks. But again, a lot of time patient is irritable and he's not keeping the mask. It is leak, it is not properly kept. So the FiO2 delivers will be much lower. So like a sick patient in the emergency, this is the first thing which we can use. And other disadvantage is that CO2 rebreathing can occur if the flows are not properly kept. And if it is not properly applied, a lot of wastage of oxygen can happen, which is also a concern for us. So now the patient is not improving. So like the patient I showed, he needs a higher support, or a patient who is coming in a critically state, like a severe septic shock patient or severe ARDS patient, where immediately you're not going in for intubation. You need something to support his oxygenation. You want to increase the oxygen reservoir. You want to increase his oxygen reservoir, oxygenation levels in the blood. So for that, you go on to escalate your support and you use a rebreathing and a non-rebreathing mask. So basically, these are like a simple mask, but they have a reservoir bag. So they have an extra oxygen supply. So basically, in between the breaths, if the child wants to breathe, he can get a higher oxygenation concentration with the reservoir bag. So it's almost like a 1 liter bag attached below your mask, where the child can get extra oxygen. So we have two types. One is non-rebreathing and one is rebreathing. Basically, in rebreathing mask, you are rebreathing your exhaled gas. So as I showed in this figure, the exhaled gas is going inside the reservoir bag, and the patient is rebreathing it. But which may not be appropriate for all the patients. So, and practically non-rebreathing mask we are not using. What we are using is we are using a non-rebreathing mask, which is more practical and which is more useful because it will give you almost 100% FiO2. Because you're using a mask, it has a valve. So whatever oxygen is coming, it is going inside a reservoir bag. So the reservoir bag is full of oxygen. So in between the breaths, if he needs more oxygen, the child can breathe through the reservoir bags. And because of this valve, nothing is leaked outside. It's a one-way valve. It's a closed system. So that is a major advantage of it. But then again, make sure that the oxygen inlet or the air support is always there, because if the oxygen support is blocked, this system being a closed one, the child can have a lot of CO2 rebreathing. To protect that, there is one-way valves on the side, which will pop up so that CO2 toxicity is not there. So that is one disadvantage. But otherwise, NRM mask is what we use for almost all our sick patients. So as I mentioned, FiO2 of almost 100% can be given, but you need very high flows, almost like 12 to 15 liters. So like this patient, like she was a girl, very hypoxic child, and we have used the NRM mask on that. So advantages basically gives you higher FiO2s in this, but again everything depends upon the patient's ventilatory effort and whether there is a leak or not. So now as I mentioned that in all these devices we have no control on the FiO2. What if we have a device where we can give the exact amount of FiO2? So in all these devices, we did not have any oxygen control. We just kept 2 liters, but how much FiO2 was going, we do not know that. But if you have a device where you can keep an exact FiO2, and then you will know exact amount of oxygen, exact amount of air which is going, that will be useful for me, especially in my chronic patients where oxygen has to be limited, or in any acute patient where I know that FiO2 of 40% will not help. I need to increase the FiO2 60 to 80%. How will I do that? For that, we have something called as a Venturi meter. So basically, Venturi meter is again your mask, but connected with a device called as a Venturi meter, in which there are fixed oxygen flow rate has been mentioned, and how much the ambient air is going, that is also mentioned. Okay. So this Venturi meter works on the principle of Venturi effect. And basically, what is Venturi effect? It is basically what we've learned in the physics, that whenever there is a very high flow, it is valid for gases, it's valid for liquid also. So whenever there's a very high flow of a liquid or a gas, the pressure drops when it goes through a narrow orifice. Whenever that liquid or air goes through a narrow orifice, there's a drop in the pressure at that point. And that drop in pressure sucks in the air from the surrounding. So that's why this device is also called as air entrainment devices. We know the fixed amount of oxygen. We keep it like 4 liters, 8 liters. And we know how much air will be trapped inside, how much the final air will be blended, and how much FiO2 will be delivered. That will be given, that will be mentioned in this. So here a very precise FiO2 of 0.24 up to 0.6 can be given depending upon the oxygen flow rate. So as I have shown in this photo, the oxygen is going from the middle valve and the air is mixed, and the diluted air is oxygen rich depending upon the flow rate. Exactly how much oxygen, how much air is going, if you want to know that, you can calculate from this formula. So this is the formula: 100 minus FiO2 divided by FiO2 minus 21. So if you want a FiO2 of 40%, and if you are giving a 10 liters of oxygen, then with this formula, you can see that air has to be 3 times the oxygen. So for every 1 liter of oxygen, you have to give 3 times oxygen, and that will make the total flow of 40 liters. So in that 40 liters flow, which is a very high flow, you are giving 10 liters of oxygen. So this is a color-coded Venturi meter from 0.24 to 0.6, depending upon this. And this is what I'm mentioning. Look at the green one and look at the white one. The orifice in the white is small, so it is it's very small. So less oxygen is going, but more of dilution is happening, and that's why FiO2 is just 21% versus this green one, where the dilution is less and the FiO2 is more. And next is the oxygen hood. So this we have been using previously, but nowadays we are not using because a lot of oxygen toxicity happens with this. So just to summarize, depending upon the device, like if you need a FiO2 of 40%, you use nasal cannula. If you need FiO2s, higher FiO2s, like up to 60%, you go on to oxygen mask. But if you need further flows and further FiO2s of like 100%, you go on to a non-rebreathing mask. And if you need fixed FiO2, then you go for a Venturi mask. And some tips for office practice is that always be vigilant. Every 30 minutes, look at the oxygen status of the child. If the oxygenation is worsening, FiO2 requirements are increasing. Escalate your device, use your device judiciously and escalate accordingly. Use a Venturi meter and come down as and when the FiO2 requirements are reducing. So now we have discussed the oxygen devices in terms of FiO2. Now we know I have given an FiO2, I have given an oxygen, I am happy. But what if the child is getting distressed? His pneumonia is worsening. He is not improving with your oxygen support. You are giving 10 liters of oxygen, the saturation is not improving. What is missing at that time? So what is missing is that we have to give some pressure. We have to open the alveolus. Our alveolus are collapsed. We see the X-ray, there's a consolidation. What is a consolidation? The alveolus is filled with the exudate. You need to open that alveolus. You need to push in the oxygen. And for that, we need some amount of positive pressure. And then now when we want to escalate our therapy, we go on to next support, which is called as a HFNC. It's a beautiful machine. It has standardized everything in the ICUs and the emergency room. And we have used HFNC now in almost all the patient as a first line therapy. So basically, as the name suggests, it's a heated, humidified, high flow oxygen. So it is also a high flow thing. It's a high flow support, oxygen support at the rate of 60 to 80 liters is going. But what is the side effect of that? When you give 60 to 80 liters of oxygen, there's a lot of drying effect happens. I mentioned in nasal prongs and mask, lot of flows are going, but they are drying up the secretion. But I did not talk about humidification. So now when I talk about HFNC, because you are giving 60 to 80 liters of oxygen, it will have a lot of drying effect. So how to overcome that? In this HFNC, basically we are using a humidifier. So we are giving humidified, heated oxygen. So humidified to prevent the cilia of our nose. They should not be destroyed. So we are giving humidified, and we are giving it warm to match our core body temperature, so the body temperature doesn't drop. So we heat it. It's a servo control. Automatic temperature is controlled by 37 degrees, and humidification, a relative humidity of 100% humidity and absolute humidity of 44 milligram per deciliter is what is advised. So we give this. And in this also, as I mentioned, since it is a high flow, you can regulate your FiO2. So FiO2s from 0.21% to 100% FiO2s can be given through this. So what are the advantages of HFNC over all these things which I have mentioned is that, first of all, since it is a very high flow, it is meeting all your inspiratory demands. And it fills your nasopharynx with oxygen which acts as a reservoir. So it is reducing your anatomical dead space. CO2 washout is happening. Then, as I mentioned, it is giving such a high flows. It is going up to the alveolus. It is opening up your alveolus. And there is some PEEP effect, which we cannot measure directly, but the studies have shown a PEEP of around 4 to 6 centimeter of PEEP can be there, which is a positive pressure. And that improves your FRC, and that improves the patient distress. Patient becomes so relieved when you start HFNC. Is a market improvement within like 10-15 minutes of starting your HFNC. And obviously the mouth is open. It's just a nasal prong. And the mouth is open. The child can feed also, and it's very comfortable. So there are two types of available. One is AIRWAY 2, which is a standard which is available. And this on the right side I have shown. So there's a machine there. So on the right side, we can see the machine. So there's a display which is I have shown on the left side. So you can regulate the how much flow is going. So on the left lower side, you can see that the temperature is mentioned, the flow rate is mentioned, 30 liters per minute, and FiO2 how much is going. I am able to regulate in this. That's the most important. Okay. So start with 21%, go on escalating 40, 50% and increase your flows, and that will give you a PEEP effect and the child feels good. Versus in some, because this is a very costly, it requires a separate device, separate tubings also. So we have always also devised our this is what we devise in ICU also for patients who are not that much affording. You can use just a humidifier and use a blender, because basically it is giving a blended oxygen with a humidifier here, and then you can use it like a HFNC. So that is like 1/3 the cost of a standard airway systems. So how much flows to start in this? So to improve oxygenation, you need to have a minimum flow of 2 liters, and there are formulas like 2 liters per kg per minute. So for a 10 kg child, you can give around 20 liters of flow. For older kids, up to 40 liters. For adults, 60 to 80 liters of flow can be given. And these are specialized nasal cannula, which are very soft, which is available. These are color coded depending upon the age and the weight of the child. So HFNC is used in all the is useful. There's a wide spectrum of patients where you can use for all the patients, for all your bronchiolitis, for all pneumonias, and it is very useful, particularly for me as an intensivist, because I extubate almost all of my patients on HFNC. So it decreases my reintubation rates and decreases distress in almost all the patients. Okay. Now, from HFNC, as I mentioned, I know how much FiO2 is going, but as I said, it gives me a rough estimate of the PEEP. What if my child is deteriorating further? He needs a more specialized support. In that cases, I need a support which can give me a more positive pressure, because now my work is not going on with a small PEEP. I need to have a support. My alveoli are filled with exudates. There's a dense consolidation. I need to have a more support, more positive pressure. And that is where non-invasive ventilation comes. And this non-invasive ventilation, here we know the exact FiO2 and we set something which is called as a PEEP. So what is PEEP? It's a positive pressure to open your alveolus. We all have a mild amount of PEEP in our alveolus, in our lungs when we are breathing, but this gives a higher PEEP. So PEEP setting starts from 5, we can go up to 10 like that, depending upon the condition, depending upon the distress, and depending upon the oxygenation targets you are keeping. So you can have a standalone machines called as a CPAPs and the BiPAP. In that, we have support. We can do the settings like I have shown. So there are settings like IPAP and EPAP, depending on how much support you need, or you can give the NIV through a ventilator also. So nowadays, ventilator has a dedicated support. NIV support is there. So from after extubating the child, if you need an NIV or before going on intubation, you can try an NIV, same ventilator, same circuit. You can start a NIV. That will reduce the cost also. NIV masks are different. So always select the appropriate mask. Look at the sizing guides are there. Every mask has a sizing guide. So medium, large, and small. So what normally medium to large is what is mostly used in ICUs. So you take the size from the nose to what covers your mouth. So you use that appropriate mask. Always look at the size and then apply it appropriately using the head straps. Keep the child comfortable, and then you start the ventilation. You might need some sedation, but at the end of the time it is tolerated very easily. So all of these are patients which we have used NIV, and this is the standalone machine on the right side where we use it. NIV is very useful for our hypoxic patients, like these two kids which had obstructive sleep apnea, airways compromised, oxygen is not going. They have a lot of they might be like a compromise of the airway, because they have this obstructing airways, large tongue. They have a lot of them have snoring issues. Lot of them have hypercapnic respiratory failures. CO2s are elevated where we don't even know the CO2s until unless we do a blood gas. So in these patients, NIV support at home also is giving. So this is basically to increase their reservoir and provide a good oxygen support. I will touch briefly on this NIV on this nebulization. So another component of oxygen therapy is like in specifically a type of patients like asthmatic patients, where you need to nebulize them. So you have given oxygen, but sometimes you need these bronchodilators, especially in these asthmatic patients, where nebulization along with the beta agonist will improve their oxygen status. So for nebulizations, we have been using jet nebulizer and ultrasonic nebulizers, but nowadays we prefer VMN. These are vibrating mesh network. So these are VMN. These are the newer ones. They are more effective. A normal nebulizer, which we are using, just gives you around 10% or 15% of drug deposition. But nowadays we are using these vibrating mesh network. These are available. So as I have shown on the right side, this gives on the efficacy is almost more than 60% efficacy. So that much amount of drug is going into your body, and the side effects of the drug also is reduced. So these are better used nowadays, and this is electronically controlled. You do not need any oxygen or airflow support for these children. Just I'll touch on it. In ventilated patients also, you can use these inhalers, as I have shown. And these are the specialized ventilator circuit where we have used vibrating mesh networks. So you connect this on the inspiratory limb, the blue one, and the patient can get these medicines effectively. Okay. So we have progressed. We have we have gone from nasal cannulas, but the child needed more. So we escalated from nasal cannulas. We went to masks. Then we regulated the FiO2 because the FiO2 requirements were going high, 60%, 70%. And then we went to HFNC and NIV where needed some PEEP. We needed some positive pressure. But now the child is going for respiratory failures. None of these things have helped the child. Child is going into a respiratory failure where despite these efforts, despite these machines, the oxygenation is not improving. Your PO2s are low, are reducing, and the child is going for respiratory failure. And if you don't monitor or don't escalate the therapy, the child can go in for cardiorespiratory arrest. So there comes, we have to empirically intubate these child kids in the ICU. And next of my few slides will be on how to manage hypoxic changes and oxygenation changes in these patients. So as I mentioned before, beginning of my slide, pediatric airway is narrow at the glottis, the subglottis part, and the need for oxygen support is crucial in these kids because they can deteriorate rapidly. Any edema here in sick patients or any insult to this part of the airway can easily compromise and can lead to cardiac arrest in these kids. Okay. So while maintaining the airway, now as I mentioned, this is not for only for the ICU patient. This airway management starts from the ER. So again, going back to the emergency room, you have a child who's coming in distress, not maintaining saturation. What do you do first? You start oxygen. That is right. But you do, as I mentioned, clear your airway. So suction the airway. Suctioning of the airway itself will improve your oxygenation. And next best thing will be the opening the airway. So suctioning and opening the airway by maneuvering the airway is the first thing you will do. Even before you apply the oxygen, do this first, and that itself will improve the child. So airway, as I mentioned, so there are three types of airway. One is the airway which is patent, which you all like at this point of time, we are conscious, we are sitting, even if we are sleeping, even if we are lying down, our airway is open. But a compromised airway which is not being maintained, maybe because of the illness, maybe because of the hypoxia, maybe because of some neuromuscular, or maybe because of some head injury, the airway is threatened. So how do you maintain that airway? A simple maneuver like a head tilt and chin lift. Okay. So what are we achieving by this? We are opening our airway. So what do we do with this? When we head tilt and chin lift, our airway is open. Why? Because our airway normally is at an acute angle. So the oropharynx and the laryngopharynx, they are at an acute angle. The trachea, the nose, they form an angle. So when you do a head tilt chin lift, everything comes in one open line and there is least resistance to the air which is passing. The tongue which might fall while we are lying down is also supported with this maneuver and the airway is fully open. In cases of in patients like head injury patients or who are unconscious, they may not be able to maintain airway because of their tongue falling, which may obstruct the posterior pharyngeal airway. So you do this maneuver, and especially in case of cervical injury patient, head injury patient, always keep their cervical cord stable. Don't just move them. Just for applying oxygen, don't move them because they will injure themselves. And there's something maneuver called as MILS, mid manual inline stabilization. You always have two people holding the head like this, and don't let the head move. Rest your arms on the table on which the child is lying down, and support the head so that it doesn't move. So you always need a team. Almost 4 people you need to stabilize the child, with 2 people, especially for the airway only. So any unconscious child whose airway is threatened, not maintain saturation, you have done the suction, still the saturation is not maintained, you need something to support the airway, and for that we have adjuncts, and we have oropharyngeal airway, and we have the nasopharyngeal airway. So one is going into your oral cavity, oropharyngeal, and one is going into your nasopharyngeal. How do you decide for this? Patient who is totally obtunded, unconscious, like post-seizure or post-head injury, who doesn't have a gag. So you can, and the tongue is falling back. So you can put something into the mouth to push the tongue forward to open the airway. Okay. And in those cases, the oral pharyngeal airway is very good. Various sizes are available from 4 centimeter to 10 centimeter. How do you measure it? You measure it from the incisors to the angle of the mandible, angle of the mouth, and you measure this length, and you select the proper size. And similarly goes for nasopharyngeal airway. Nasopharyngeal airway goes into the nose. If patient is like a semi-conscious patient, or even in a conscious patient, where they will not tolerate a oral pharyngeal airway, because if you try to put a OPA in a conscious patient, they will vomit or they will injure themselves. So you cannot put a oral OPA, or if they have a mandible injury, you cannot put a OPA. So there you need to put a nasopharyngeal airway. In those kids, the NPA is put, and it is tolerated. It is very soft also, versus OPA, which is a very hard plastic substance. NPA is soft like a rubber. Easily it is put through the nose, and you can give oxygen through it. You can suction through it. Okay. And so this is how you put a NPA, measure it from the lateral edge of the nostril to your tragus of the ear, and then you insert it. So both of these will help you a better resuscitation. Airway is open. With the OPA, you can give bag and mask ventilation also, because tongue is not obstructing your oxygenation. You can give a proper bag and mask. Effective CPR can happen. These are some of the cases where the nasopharyngeal airway has helped in, like in case of airway malformations, like in case of Treacher-Collins or Pierre-Robin syndrome. It is very useful in post-op patients. This is how you measure. This is how it is placed, and will help us, which will help us very much. Versus if you need to have more specialized devices, these are supraglottic airway devices where you can ventilate also. So this OPA, NPA, it is good to maintain passively, but if you want to actively ventilate the child, even if you want to do an intubation through these devices, it can be done. Because as I said, you are giving so many high flow oxygens are giving, and you are bagging. There's a lot of gas is going in the stomach. Stomach can dilate, they can vomit. So you need devices where you can decompress the stomach also, you can ventilate also, all combined. You can use these devices called as LMAs, laryngeal mask airway. So I've shown these devices. How to insert is that you hold it like a pen, and you follow the curvature of your mouth, of your oral cavity. In smaller children, you can put it directly, you can go directly and put it over the larynx. Once you start using it, practicing it, it needs some practice. But once you are through it, it will be very useful. These are like your intubation. You can prevent intubation. So many procedures, bronchoscopies, and so many upper airway procedures can be done with the help of these. So just put this, and then you can ventilate. And plus, as I mentioned, the newer ones like the iGel and the ProSeals, which are specialized LMAs, you can suction them. You can suction through them. You can deflate. You can put a NG tube through them. And even you can put LMAs also. So there are, you can put ETs also through that. So there are intubating LMAs, ILMAs. All those are available for us to improve the airway stature in these children. Sizes are mentioned. They are color coded also. And now proceeding towards the last part of my topic. Now the airway needs to be secured. So it's a very critically sick patient, head injury, severe ARDS, where all these instruments will not be very useful. Airway is still threatened. You need to give medicines a lot of sedation has to be given, or muscle paralytics has to be given depending upon the condition. Like in case of head injury, where the child has ICP, where you need to totally knock out the patient. You have to give a lot of sedation, paralytics. In those cases, you cannot use these devices for a long period of time. You need something to secure the airway, to stent the airway, and in those cases, we have to intubate the child. So intubating these child is a very critical thing. That these children have low oxygen status. There is a lot of hypoxia. They don't have, their FRCs are gone. They don't have the drive, and these children can collapse as soon as you give these drugs like midazolam, or if you give paralytics without proper airway support, these children will collapse. So there comes what is called as rapid sequence intubation. Okay, you need to take control of the airway very fast to maximize the chances of intubation, to minimize the aspiration. These kids are coming in the ER, you don't know the NPO status, and sometimes this airway will be threatened. So you don't have time. You cannot apply these NRM masks, wait for things to happen. Quickly, within like a minute or 2 minutes, you need to secure the airway. For those, we need to do a rapid sequence intubation. Rapid means securing the airway fast, rapidly, and in sequence. What is sequence? There is a sequence of events which is followed before you give a paralytic and a sedative drug. So there are two types of RSI, where you don't give any bag and mask ventilation. Child is coming, you give this medication, knock him out, give a paralytic, and intubate within a minute. So this classical RSI, no bag and mask ventilation. You don't have time for that, but you do still give a cricoid pressure to prevent aspiration. So nowadays we use a modified RSI, where the child needs oxygen, he's hypoxic. You cannot go without a bag and mask ventilation. You need to increase your oxygenation status. So you need to give a bag and mask ventilation for a few minutes, and then you give the drugs. And here you don't need any cricoid pressure. So there are multiple steps which have been described. It can go, there are 7 steps, 9 steps, so many steps are there, but just remember the sequence. Sequence is important. Okay, so we go from planning. How will we go? We divide the roles. We call the most experienced person for intubation. We call off the nurses. We call the specialized team. All my fellows, all the, if required, ENT person or anesthetist may also be called. So plan, depending upon the condition. Head injury patients will require a separate plan. Septic shock patients or myocarditis patient require a septic plan. So we'll have a separate plan. So have a plan, then prepare the drugs. Immediately give the orders to your other fellows or the nurses that, yes, I'm expecting this complication. Keep ready a lignocaine. If it's a head injury patient, keep ready lignocaine, keep ready atropine, and get a muscle relaxant, rocuronium. Just tell them this is the plan and keep the things ready. If it's a head injury patient where you're expecting a cervical injury, protect the cervical spine. As I mentioned before, don't move the spine. Don't do head tilt chin lift. There you only do a jaw thrust. I'll come on that. So just do a jaw thrust and secure the airway. Meanwhile, somebody takes care of the oxygenation by putting maybe an NRM mask, and you proceed for intubation. So pre-oxygenate, pre-treatment. Now you give those drugs which I mentioned. Give lignocaine, give fentanyl if it's a raised ICP, because you don't want that noxic stimulus going on. And if it's like a myocarditis patient, keep adrenaline ready, start adrenaline infusion, and then proceed for intubation. And then once the things are controlled, then you paralyze, and then you put the tube. So briefly, let's look at it. So this is the mnemonic for preparation. It's called SOAP Me. Dr. Maninder had already shared these things in the WhatsApp group. So keep suctions ready for oxygen, keep oxygen ready as mentioned, airway supplies, all the things, LMAs, bougies, stillets, everything which is required for intubating. Keep all the drugs ready, P for pharmacology, and keep all the equipments. Have your monitors ready, have ETCO2s ready. Then have proper ET size, ET lengths. Okay, so we always use a cuff tube for all practical purposes. We are only using cuff tubes for 3.5 and above. All cuff tubes are there, so we have to use. We should know all the size. Have your Breslow tapes as per the PALS. You should know the weight, what sizes tubes are there. Everything should be there in a ICU or in a ER setting. So protocols should be set for that. So we know the ET size. We have formulas for that. So these are the ET. This is the bougie. Have proper laryngoscopes blade. You have size 0, 1, 2, 3. For 1 year of age, you need a straight blades. These are Miller blades. For more older adults, you need Macintosh blades, which are the curved blade, have proper sizes, proper functioning. Light should be there. They should have proper batteries. Have your monitors, keep capnometer ready, and keep your drugs ready. And then uh, a good assessment is verbal assessment to estimate whether the child has a difficult airway or not. So Dr. Ketan can talk about that, can tell us about that in the next few slides. But I'll briefly mention that for an assessment of a difficult airway, it begins with assessment by looking at the child. So there's a mnemonic called lemon. So look externally, look at any malformation, look any neck swellings. Then you have the 3-3-2 rule. So 3 fingers should be able to be go into the mouth. That means adequate mouth opening is there because you're putting a laryngoscope, ET. So mouth opening should be adequate. 3 fingers for mouth and 3 fingers for hyomentoid. So mentum to hyoid bone, 3 fingers should be should go adequately. That means there's enough space for the things to go. That your tongue is not large. And next is the thyromental distance to see the position of the larynx. So 3-3-2 rules should be there, should be done. Then we do a Malampatti score. So depending upon the grade. So grade 4, where you're not able to see the uvula, you're not able to see the posterior pharyngeal space. That means it is going to be a difficult intubation. So grade 3, grade 4 is very difficult. I will be extra careful. I will have everything ready for an emergency intubation because these patients will give me a nightmare if I'm intubating this child. Then, as I mentioned, airway positioning. Again, if you have not mentioned, if you have not maintained the airway till now, again go back to on this. We want to maintain the airway. That's the foremost important thing. So you can use adjuncts. You can use a shoulder. You can use a shoulder roll or a headrest. Basically, it is on the bedside only. There's no hard and fast. We have to use a shoulder roll or a headrest. Simple head tilt chin lift will improve your airway. Airway will become more streamlined. Or sometimes you need to use an adjuncts like a shoulder roll or a head roll for bigger kids so that the airway is open. And once you're able to see the vocal cords properly, then you proceed for intubation. Now you have positioned it, oxygenation is still less. Don't just rush in for intubation. Okay, dalna hi hai ET, I will give the drugs, I will proceed. No. Improve your oxygenation. That is the motto. That is the message today. Improve your oxygenation, maintain the airway, not maintaining, position it, not maintaining. Then you go in for extra oxygen supplies. You might be already on NRM oxygen, which is not helping. Then you need a positive pressure. You use a bag and mask ventilation, which I have used there. Use the proper mask. These are proper silicone masks are available, which will give a proper seal. Somebody is maintaining. So you can see the head tilt chin lift is being maintained. Manual inline stabilization is being done. Head tilt chin lift is being done. Proper bag and mask is being done. Ensure an oxygenation for at least 5 minutes. Maintain a saturation of 98% so that you have a good apnea time so the child doesn't desaturate. And then you proceed for intubation. These are the drugs. So you need to induce, you need to sedate to take off all the reflexes. The child should not gag. The child blood pressure should not collapse. The child, if he is having a raised ICP, like in case of head injury patient, should not have a sudden surge of ICP. So you give drugs like ketamine, midazolam. If they are seizuring, you need to give a midazolam, razepam. And then you go for sedation like ketamine. And then once the child's reflexes are gone, you also have used a lignocaine if it's ICP, or if it's a myocarditis patient, give a inotropic support like a adrenaline. Keep ready. And then you give a paralytic. Once you secured the airway, oxygenation maintained, I am now convinced, yes, I can intubate. I've seen the glottis. Then you proceed for intubation. So give your paralytic, which can be a short acting like a rocuranium. And with that, you proceed for intubation. It's always a good practice nowadays. We have video laryngoscopy because still you can have a problem. If you're not able to visualize the cord, video laryngoscopy is very useful. And sometimes to see the cord, we do this manual called as burp, where you push the the thyroid cartilage up, backward up, and right side to visualize the cord properly. So this is more of an intensivist point of view, but you should be aware of this. So post intubation, good practice to have a ETCO2. It will tell you whether there's a tracheal intubation or whether you have misplaced the tube. So once you get a good waveform, you are convinced that it's a good waveform. Then do an ET check with the X-ray also and look at the chest rise. So that will tell you the ET is in position. And then you have something called as physiological difficult airway. So I see a lot of patients in the emergency room. We see a lot of myocarditis. We see a lot of head injury patients, septic shock patients. These are particular categories of patients which are at very high risk. So they need oxygen support, yes. They need positive support, yes. But what is threatening me at right that time is their physiological condition. Hypoxia can kill, but then a poor cardiac function or a poor sensorium, like an active ICP or active seizures, will kill the patient if it is not handled properly. So they are a difficult airway. So this is different from an anaerobical airway, which I've already mentioned how to look at it. Something manually, something mechanically obstructing the airways, anatomical difficult airway. But this is physiological. This is something which you have to know and see at the bedside. So many of our myocarditis patient or ICU patient will be lost if you go ahead and directly intubate, and this then can lead to collapse, cardiovascular collapse. So hypoxemia, hypotension, severe acidosis, raised ICP, myocardial dysfunction is one particular set of patient which I'm very concerned as an intensivist, and I tell my fellows, be very careful. So I'll just take 4 or 5 minutes. So just finishing. So these are few cases where this physiological difficult airway has been told. So this child had a history of fall from stairs and was posturing in front of me, 6-year-old child, and something bad is there. There's a lot of gurgling sound. So that tells me the airway is threatened. Suctioning might help, but not much because the sensorium is gone. The GCS of this child was just 8. Pupils were unequal. The child heart rate was low. Blood pressures were high. So that is giving me an idea that the child is having a ICP. So there is hypertension with bradycardia. Child is having a Cushing reflex. Maybe child is going in for coning. So that this is very risky for me. So I cannot go over directly to intubate this child. I have to prepare this child. So all the things are ready: bag and mask ventilation, laryngoscopes, drugs, and then again I follow this sequence. I anticipate ICP. I give lignocaine to remove the noxious stimulus. I give fentanyl opioid to remove the painful stimulus and deepen my sedation. And then with proper bag and mask ventilation, I intubate this child. So this child was in the ICU. CT was bad, showing severe cerebral edema. Shows, yes, my diagnosis was right. The child was having persistently raised ICP. You can see that hypertension, bradycardia is persisting on the monitor. And this child was managed with utmost neuroprotective care. Versus this child, 10 months old child, has fallen from first floor and has come with altered sensorium. There was a lot of bandage on the head. You can see how much blood was there. And this child had gone to 3 hospitals with a lot of bandages was done. The child was shunted from 3 hospitals because they didn't have the facility. The child has come to us with cold, clammy extremities, and there is massive blood loss. Saturations were 70%. The child had a lot of pooling. And this child, we are expecting neck injury. So airway maneuvers has to be carefully managed, and then oxygenation status has to be improved. A lot of pooling. The whole mouth was full of blood. We were suctioning, giving NRM, but the child was having ICP. And you look at the blood gas, lactate of 14, and look at the HB here, just 3.9. So child is in a hemorrhagic shock. There is low HB. That is compromising your oxygenation status. Lactates are so high because of hypoxia. You need to manage this child immediately. This is a nightmare. But since this child came very late to us, the child did not survive after 1 day. Then this was a case of community acquired pneumonia. You have the X-ray. The child came with this pneumonia, severe ARDS. The oxygenation status is very low, not saturating even with non-rebreathing mask. With 100% FiO2, the child was saturating only around 85-88%. And the child progressed very rapidly. The PF ratios were down to just 88. The PO2s were just 68. So on high FiO2s, the PF ratios, the oxygen status is so bad. So the child needs immediately intubation. So after NRM, we go directly to intubation because the oxygenation is very poor in this child. This case, another very common case. So 9-month-old baby came to us with distress. This was the X-ray. Again, there was cardiomegaly and there was some shadows in the lungs. When we look clinically, the child has tachycardia. The pulses was not there. The child was hypoxic, saturation just 90-92. The child was cold. The extremities was very cold. It was bluish. Mother said the child was turning blue in the morning, not taking feeds, so irritable. Myocardial patient will be so irritable. They are so hypoxic. So here, the cardiac output is low. So as I mentioned initially, the DO2, your delivery of oxygen is so compromised there. The cardiac output is so low. The child is very irritable, and this child can collapse. This is one of the biggest nightmare for us. A myocarditis child coming with distress, with hypoxia, the first tendency is to give lot of nebulization, and the case gets delayed. We do a blood gas. The lactates are so high, 8.2 of lactates. In this case, severe acidosis. This child is a nightmare. This child can collapse if you don't prepare this patient well. So, as I mentioned in my slide before, keep adrenaline ready for these patients. So, adrenaline is a savior. Keep an inotrope. Start an adrenaline, anticipate, prepare the patient, anticipate, start adrenaline, then use your drugs like ketamine, and then use inducing agents like fentanyl, and then you use paralytic, and then you go for intubation. And that is how you secure these airways. So severe LV dysfunction on echo, and we intubate this child. Coming on to the last case. This is a dengue patient. So dengue season is going on. So this is the 12-year-old kid, dengue shock. Again, this child is in MODS, poor pulses, oxygenation status is poor, intubated with all the RSI, and drugs are used appropriately. And this child needs support for his cardiac dysfunction which he had. So in my talk, I have covered, I think I have covered, and I've tried to explain how we go about the support from a nasal cannula, increase your FiO2s, not improving, go to HFNC, which is the mildest of the support, not improving, go to NIV. For some PEEP effect, not improving, go in for intubation. And finally, how to go for intubation and how to maintain the airway. Okay, so that is my message for the day. Secure the airway, improve oxygenation, save lives. Thank you.
Thank you, Naresh. I'm sure that many people would have benefited from it. Can you stop slide sharing?
Yes.
So we have
Naresh, that was very, very insightful and very wonderful presentation. I really liked it, and there are so many things to learn from that. Thank you.
Thank you, Dr. Ketan.
So before we begin to the Q&A, I'll introduce Mohite sir. Mohite sir is the ex-president of our chapter, and he has his own hospital, plus he's a visiting professor in many teaching hospitals in Mumbai. And he's a great academician and started a lot of programs in our chapter. So Mohite sir, I know you're traveling. Can you briefly tell us about the presentation and some pearls?
First of all, Dr. Mahinder, thank you very much for involving me in this program. Amazing talk by Dr. Lal. He has covered such a huge, extensive topic. This can be a program for one day, full CME, right from oxygenation, right from HFNC, right from CPAP, BiPAP. I think in the intensive care, or 1 hour each on each of these programs. Am I right? So, and he has really given us, we need to understand oxygenation and ventilation are the two components. And majority of the failures are because of failure of oxygens. So we need to be careful while handling those sick children. It is science, no doubt, but a lot of arts also involved. It's not a compartmentalization. It's not like HFNC 2 ml per kg, 2 liters per kg. At times, in front of 3 liters, we have gone up also. So, side looking at the responses of the child, we need to be really adjusting those doses. Selecting your devices, whether it's respiratory versus cardiac, sometimes the priority do change. I get a cardiac failure in a shock child. I may be just giving the may not be straightway intubating because going for intubation in the child that can be really a disaster. So I may be giving the CPAP or BiPAP device, meanwhile slightly stabilizing his hemodynamics with some small bolus of fluid followed by inotropies. And once a bit reasonably stabilized, then I will take care of the airway. So that's how the things will gradually. So it's not kind of a 1, 2, 3, 4 sequence. At times you may have to make some variation according to your experiences. He gave wonderful explanation about the airway devices, the high flow, low flow devices, which many times is not properly understood by the students. That's the reason I think I think Dr. Naresh has given a good explanation of all those topics. And if the delegates have some doubts about it, they can always ask the questions. One more comment was preparedness. All these airway devices and airway control programs rest a lot on the preparedness. So proper site, of where you're going to do this. So you're really anticipating a difficult airway in a given patient. Don't try to put it in a ER, or don't try to put it in a small nursing home or here and there, because it's really a disaster. If you cannot intubate that crux child, then it really becomes a big chaos. So choose your site appropriately. See to it that you have all the facilities available there. See that you have maybe a senior person standby, maybe an anesthetist standby, and keep your cool. Very important. When the child is struggling to breathe, many times the doctor or an emergency care specialist try to intubate child and can create. So I always believe, unless you are sure about the airway, patency, never paralyzed, preferably avoid a significant sedation as well, because the child who is struggling, he is perhaps the best judge to know what is the best way of taking care of his airway. Until the time you are sure, never paralyze this child. Take care of that airway. So again, to repeat, do it at a right location. Don't do it haphazardly, because at that position, when he's struggling to maintain his saturation at 90% with a lot of efforts, you sedate the child and cannot get the tube inside, then sometimes you may not be able to do a bag and mask ventilation, and the whole crisis may happen. So choosing that site, going through that sequence of lemon for getting over the airway is extremely important. Lemon is all inclusive kind of protocol which need to be strictly followed in any airway device card. As I already mentioned, target is to get oxygenation first. One of the very senior international faculty in this talk said, child will rarely die of hypercaribia, but he can easily die of hypoxia. So first target is to maintain the oxygenation, get to at least some optimum levels and keep it there. And then you can do all the gimmicks. A lot of controversies about high flow nasal cannula, which may come during the discussion. We have been discussing it over last 10 years. No one knows how it works, but it does work. That's a fact. As Dr. Naresh said, that most of his ventilation patients will extubate to high flow cannula. I'm sure the intensivists have their own protocols. In my setup, they will generally, the prolonged ventilation will generally go on to BiPAP device, and then as a step down, may go on to high flow. About the high flow, choosing the size, the flow, equally important is to choose the appropriate cannula size. The high flow, difference between high flow and CPAP. CPAP is a snugly fitting kind of a device where there is no leak around the mask, whereas high flow is choosing the cannula, nasal cannula size, which is about 50% of the nostril size. That is approximation, but idea is basically there is sufficient space around the cannula because there is no exhalation pathway otherwise. And while doing so, you must have, many of you must have noticed that you set up a higher flow and the machine start giving alarm that the cannula is blocked. It's not blocked. Actually, it's a size you have chosen is too small to deliver that volume and that flow of the cannula, and that's the reason blocked. So choose your cannula size appropriate for the size of the baby. That's extremely important when I talk about high flow cannula. There are so many other things which can discuss, but I think let it come from the question answer session. Thank you very much again for involving me in this show. Maninder, I think this is a very good initiative, and beginning with airway is the most important part, because every of your survival of emergency care, ICU care, everywhere rest upon a proper kind of a conditioning, proper take care of the oxygenation and airway. So thank you very much, Maninder, again, and thank you, the Delhi IIP group, for giving me this opportunity. Thank you very much.
Thank you, sir. Thank you. I'll now ask some basic questions which I had asked in the poll before. So we have asked whether NRBM is a low flow device or a high flow device. Now this is to Ketan, because in our times, NRBM was a high flow device and Naresh has told it's a low flow device. So what is your take on that, Ketan?
Yeah, I will take it. So, sorry, which is the following? Again, can you just repeat the question? Which of the
Sir,
following? So, yeah. So
so I,
non-rebreathing mask is a high flow device, because you are, see, the concept of high flow device is very simple.
sir,
You
I'll
are
ask again.
giving,
I'll ask again, sir.
yeah,
Actually,
yeah,
in our times, NRBM was a high flow device.
yes,
Now, Naresh has recently told in this PPT it's a low flow device. So I
yeah,
wanted to ask, is it true from Ketan because he's a pediatric anesthetist? And
okay,
what is his take on it? Because the
okay,
teachings are changing now.
okay,
Okay, thank you very much for that question, Maninder. So, in our textbook, it is always mentioned that it is a low flow device. It was never as a high flow device. The only thing is it gives you a higher FiO2 because of that reservoir bag and everything. But if you see, if it all depends on the work of breathing of the patient. So if breathing tachypneic, the FiO2 changes, and that's why it is always a low flow device. It
Okay.
was always a low device.
But when we give it at 15 to 15 liters, 20 liters for a small child, it might become high flow.
Yeah, it might become high flow, but then your FiO2 is variable, isn't it?
Okay. So with
So
that,
so it is not very easy to like make it into black and white. There is always some gray. So if you are using 20 liters of flows and then the kid is very small and is breathing nicely, quietly, so then obviously it will become a high flow for that.
so we have
So,
asked this.
Maninder, just can I make one statement here? The
Yes, sir.
high flow, low flow, the differentiation is how reliably, predictably you can choose a given FiO2. How dependably you can give that FiO2. I can choose to give 50% predictably in whatever distress, then it's a high flow. I want to give only 60% that's given through this device, it's a high flow. Here, this is flow dependent, patient effort dependent, so it will be low. So as you said, in a NRBM, you put 5 liters and it becomes a low flow, become 15 liter. But again, 15 liter, you're choosing almost 100% FiO2 in a given patient. I may not be wanting that. Patient is an infant or neonate, I may not be wanting. That's how it makes a low flow.
Okay, sir. Okay. So there's one more question, Mohite sir. We have put this mark that HFNC gives a fixed PEEP effect. Many people told yes. So does HFNC give a fixed PEEP or it's a variable PEEP?
No, at present, we don't have a reliable device to count the PEEP delivered by the HFNC. So it's not a PEEP device, not taken as a PEEP device. It's anywhere between 4 to 8 centimeter, but really in a given patient, we don't know how much PEEP it delivers. So that's not a fixed PEEP device. You cannot choose a PEEP through that.
Correct. So we have these HFNC cannulas which have this spring around them. The purpose of this
Yes.
spring is basically to prevent kinking in a small child, just for
Yes.
extra knowledge. And this is the HFNC circuit. If you can see, the heated wire is outside the breathing tube. It is not within, because we found within the breathing tube, it should be a clear laminar flow and there should be no condensation within. So that's why you can see the heated element is outside the circuit. Now, the next question was whether these are proprietary terms like ambu bag, RAM, and iGel. Only one person told LMA is also proprietary term, and that is Ketan. So, Ketan, I thought LMA was a supraglottic airway device, and it was the first one, so everybody loved it. So, is it a device name or it is a proprietary name?
No, it is a proprietary name. It was I forgot the company name, but LMA was like Teleflex. So Teleflex is a company. They came up with this LMA. LMA is supraglottic airway device, and Archie Brain invented LMA. Everyone knows that he invented in 1981, and he was going after a lot of companies for almost 7 years. And in 1988 this Teleflex finally agreed to develop something and they called it as a laryngeal mask airway. And it is a short form LMA and it was like patented for next 13 years. So after that, everything like jumped in and they started preparing these supraglottic airway devices. But the original name is still persistent. It is so much ingrained into the heads. It is still called as LMA.
It's like the ambu, the new ambu. Everybody says
Yeah,
ambu, it's actually
amber.
self-inflating bag.
It's actually, yes.
Bag. Yeah.
So this is how the LMA should be inserted. You hold it like a pen and you slide your fingers inside and get it done. The next question was basically difficult intubation. There are many definitions, Ketan, and they're very confusing. So what do you mean by a difficult tracheal intubation? Keep it very simple for the students.
Okay, so any intubation attempt more than 4, so according to anesthetists, so there is a association, All India Difficult Airway Association, and accordingly they have given the very strict guidelines. Like suppose if you cannot intubate a particular kid in 4 attempts, out of which one is video laryngoscopy, so it is considered, sorry, 3 attempts, it is considered, and out of which one is video laryngoscope, it is considered as difficult intubation. And similarly, there is difficult laryngeal mask airway insertion or supraglottic airway insertion also. So you can give 2 attempts, and suppose if you are not able to ventilate with 2 attempts of supraglottic airway, it is called as difficult supraglottic airway insertion. And these are like very strict, very crisp, 2 and 3, out of which one has to be video laryngoscope.
Okay. And there's something like there should be two people, operator dependent, something like that.
That was very old thing. So they are saying ki you cannot use the same technique again. So if you are using, you cannot use the same technique again. That means for the next attempt there should be some different person, or you should have something different. You can change the position, you can change the scope, blade.
So if I am not able to intubate, one more person intubates. Is it a difficult intubation?
No.
No. Okay. Thank you for clarifying that. So this is something like CPR. Everybody wants to get a CO2 monitoring. So you have CO2 monitoring devices in your ICU. You can connect it to the HME and it can easily do. You can see your CO2 happening more than 50 minutes effective. And then I asked this question, then behind the endotracheal tube, you have these many labels. So what does this label stand for? So these are basically phthalates. They are very toxic for a newborn and an infant. It's advisable if you do not have them in your central devices or if your endotracheal tubes. For adults and children, it does not matter. And this is the nebulizer that we are talking about in ICUs. You should have these mesh nebulizers. And these mesh nebulizers, somebody asked in the Q&A also, how can you deliver it to a HFNC device? So they can be easily attached into this limb. And from here, you can attach, you can give the nebulization to the patient. So it's very much doable. Ultrasonic nebulization, we never use in our ICUs at all. Then the next question was basically for the RSI, what are the various mnemonics? So somebody asked Ketan about this lemon. Is this 3-3-2 rule applicable in pediatrics?
Unfortunately, no. This 3-3 rule is only for adults. In kids, we go with a different rule, like 3-2-1 rule. So you see the like submental to higher distance. So in adolescent, it is 3 fingers. In toddlers and everything, it is 2 fingers. And then in neonates, it is 1 finger. So if it is less than that, it increases the difficulty. So all these Pierre Robin sequence who have very receding chin, there this distance not even 1 finger, so it kind of predicts the difficulty easily.
Okay. So as an intensivist, I think so we should know about soap me and lemon only, because rest of the things are mostly for anesthetists. Am I right, Ketan?
Yeah. So it kind of, so you have some basic things, and then you have some advanced thing as in every field. So yeah, these difficult airways, I think it's, yeah.
Okay, and then we asked this question about oxygen cylinders. So scuba divers do not need oxygen because they are going deep inside ocean. So they require just air because deep inside the alveolar concentration of oxygen increases. If you give high concentration oxygen to scuba divers, they will die because of oxygen toxicity. And then we asked the oxygen cylinder. We know it's a famous black and white, and scuba can be any color. Whereas you should know about the various air cylinders also which are available. So they'll be usually gray with a black and white top. So you should know how the body and the top look like. Then we asked the steroids, when should be used in pediatrics. Mohite sir, many of the people told that they will use steroids in epiglottitis and bronchiolitis. So do you think it is right to use steroids in epiglottitis, which is bacterial, and bronchiolitis? You are on mute, sir. Mohite sir, you're on mute.
It's okay now? Yeah.
Yes, sir.
So bronchiolitis, no science at all today, no evidence at all today. Epiglottitis under the cover, if you're sure it's a bacterial, like nowadays we don't see many. In my training period, we used to see H. influenza induced epiglottitis quite a lot. And in that case, under cover of antibiotic for a short duration, we used to use it, and there was evidence for that. But today we don't see. But yes, if the severe epiglottitis for a short duration, initial 48 hours, yes, under cover of steroids, we can be using it. It's the edema reducing agent in the acute inflammatory condition.
Okay. So now this is to Ketan. So this microcuff endotracheal tube, though there's no evidence of it being better than the other, what is your take on it?
I personally like them. I feel the cuff. So the problems I say is kinking, and second is post extubation crow. So all those two problems are very less when we use this particular tube, because the the cuff is very thin and it doesn't exert that much of pressure. So we conducted a study in which we kind of inflated the balloon and checked the pressure. So even after you put in like significant amount of air, which we wouldn't have put in otherwise, the cuff pressure doesn't increase that much. I'm not recommending here to put lot of air into the cuff, but it still gives you a bit of safety in terms of cuff pressure. Another advantage is the cuff is relatively shorter. So as I think you are showing it here in these examples where the same size cuff, same size tube, but the cuff is longer. So what happens is sometimes because of this longer cuff, the cuff can herniate through the cords. And suppose if you don't want that herniation, you push the tube in and the tube goes endobronchial. So this is one more disadvantage of using this normal cuff tube than micro cuff tube. So if you
Perfect.
ask me, given a choice, I will use a micro cuff tube. But unfortunately, there is some manufacturing issue, so they have stopped manufacturing it. So it is not easily available.
And there's one more answer, Mohit sir, that people are telling they will use curved tube beyond 8 years only. Is it true?
No, not at all, not at all. We have been using it even nowadays. In fact, whenever availability is an issue of a smaller size tube, that's a big problem, you know. So below number below 3.5 is not available. But whenever available, and especially when I'm dealing with some compliance problem where I'm likely to be using higher PIPs and all, I prefer to put a cup tube. But same time, when I'm using it, I should be careful about the compression effect. But is later polyurethane tube that complications related to pressure are also much less. So whenever available, even the smaller size babies, we are using it. So 8 years is too crude. In fact, at 1 year or even at 6 months, we are very commonly using cup tubes now.
So we say, sir, anything beyond 31 days, we use cuff tubes, though we might not inflate it,
I agree.
but we'll
I
use
agree.
cuff tubes.
I agree with you. I agree with you.
Okay, so this question was again about the nasopharyngeal and the oropharyngeal airway. So, Ketan, they have written many of them that oropharyngeal size is from the angle of mouth to angle of mandible, whereas Naresh told from the center of the teeth. What is your take on that? How do you measure? Because there's a lot of confusion. Some books have written angle, some books have written the center of teeth.
So I think, okay, there is nothing right and wrong answer here. It all depends. See, in medicine, 2 plus 2 is never equal to 4. So I think what Naresh has said is just like a starting point. And suppose it doesn't work, it's not like, okay, this is the only airway which I can use. If it doesn't work, if it is very, very big and it is causing a lot of gag reflex, or it is going, the air is directly going into phagus, you will take it out and put a smaller one. But this is angle of mouth to angle of mandible will usually give you a like shorter airway, which will then what happens is it will end somewhere in the base of the tongue. So the tongue will be still there, which will cause obstruction. So I feel better way is what Naresh has said. Start from the center of the mouth and then use that as a starting point and then go accordingly.
Then the confusion goes to this nasopharyngeal also. Now they are saying the lateral edge of the nose, philtrum or the nose tip, which should be the beginning point as per you. Because some books have written the lateral edge, some books have told the philtrum. So what do you think is the right way?
I feel what Naresh has said is easy and easy to remember, so go with that.
I think actually not much difference. It's just how you put it. So estimate to decide that.
Yeah.
So different books have given different answers. I've also seen that.
So here as you are showing in your B figure, that the airway becomes smaller and the base of the tongue is still there to obstruct the airway.
Correct. So we can insert the oropharyngeal by either way.
Maninder, can I take a?
Yes, sir.
Maninder? Yeah. See, I understand the numbers and guidelines which are given, but on the bedside, even if you go for the ET tube, you're keeping 0.5 down, 0.5 up, length up and down. Many times you see that you have measured it and you've taken an X-ray, should looking too much in or too much out, and again you adjusted. So don't go with a number. These numbers are just kind of a gross guideline for the beginners. Once you set in, it's a point that you should be looking where exactly it plays, whether it's delivering. Ultimately, the oropharyngeal and the nasopharyngeal should rest at the opening of the airway. So it may not be always accurate. We have seen so many times following these guidelines, and again you'll have to reset it. So go with a complete statement, follow these numbers, check that it is delivering properly. If not, then adjust according to given patient. I think that can be the good way to go about. There cannot be a single number which is always true or always, right or wrong.
Agreed, sir. This was basically for MCQs. Sometimes the students are fixed with
Agreed.
the.
Dr.
There are some
Maninder, Dr. Maninder, please
I'll just take 2
conclude.
minutes more,
Please,
Shyam.
please conclude. We already half
I
an hour
know.
we
Just
took
take
the
2 minutes Q&A session. So
Yes.
this question is for Naresh. They are telling that while intubating, many children die. So you told about the concept of physiological difficult airway. Only I'll answer the questions that means because time is less. So basically, once you're preparing for a trip to your any vacation, this is like a simile. You prepare many number of things. You prepare your suitcase, you prepare your lunch, you prepare your water. Like that is the intubation. You are going for a journey of mechanical ventilation. You need to prepare your equipment properly, be ready for the disasters or the road failures that can happen. So, but if you're not able to recognize that there's something going to be wrong, like a physiological difficult airway, don't blame it on a vagal stimulation. Vagal stimulation will not cause the deaths. It's basically the child was sick to start with. We were not able to recognize it. And then we created more damage by paralyzing him or sedating him because that was the compensation mechanism. The rest of the questions, I think so, Naresh has already answered in the Q&A. So with that, one word from Mohite sir, Ketan and Naresh before we close the session and then over to Dr. Meena. One word, Mohite sir.
Yeah. So before doing the airway appropriately, choose whenever possible, choose the right place to do that, where every preparation is very well made. When there is no option, you will have to do wherever you're landing. But when there is option of some time in hand, take him to a safe place and handle the airway. Don't do it in any emergency
Perfect,
place.
sir. Point very well taken. Ketan, one word of wisdom from you.
So thank you very much for this opportunity first. Second is now we are living in an era of collaboration, not competition. So I might be the black sheep of the group, but whatever I can learn from you, there might be some things which I will be able to do better so that you can also learn, and so we both grow together. So thank you very much for that opportunity again.
Wonderful words. Naresh, thank you for the
Absolutely.
presentation. Perfect. Can you give one word of wisdom? Yes, trouble the connection again, the sound. It's okay. So we'll give it to Shyam Sundar. Meena, thank you for giving us a chance to present. Meena, it is all because of the vision of Delhi IIP to create such great modules and giving us a platform. Over to you, Meena.
Thank you, Maninder. First of all, I would like to thanks to our speaker. It did the wonderful job, such an informative talk. And I would like to thanks to our chairperson, Dr. Mahesh Mote and Dr. Kulkarni for
Thank you.
the valuable additional input. Thanks a lot. And Maninder, you are betterly now. You are the one of the best person to make this program in the positive way. Definitely, because in the beginning we can see the or more than 150 or participant here, and majority of the participant is a resident. So they really like such a wonderful informative programs. And thank you.
Thank you. Thank you, everyone. Let's meet again next week. And the topic would be on shock and vasoactive agents. Bye, everyone. Thank you.
Bye bye.
Thank you very much. Thank you very much. Thank you.